morning, everybody. It's really a pleasure to be here at MHIF Grand Rounds and have the opportunity to speak of a very timely topic. And thank you for our sponsors, Amgen and Janssen Pharmaceuticals, for supporting us. So, today our Grand Rounds, this is pretty much as actionable as it can be because we'll be talking about the science and some of the data behind this. But for our practice, if you haven't heard, I guess I'll make the formal announcement now. This is something that is happening by January 3rd, so we're just about a month away from this, and this is an opportunity for us to educate about what this change means and how to best approach this and succeed. These are my disclosures. I do have to disclose that I consult for the primary manufacturers of the I and the T assays and have a patent related to that. So high sensitivity implementation, why and when? If at some point you're getting several consults, do not feel obliged to blame me. This is pretty much something that has been in the works at the ELINA level for some time, particularly because the ELINA's fleet of chemistry analyzers are pretty much at the end of life. They've been working for quite some time at the laboratory level and trying to figure out who they were going to contract with. As you may know, for any large equipment, this is a very competitive process. And long story short, the decision was that they were going to move to Roche. And that's pretty much what we will be talking about today, about what that means clinically. What this means is that by early 2023, the entire ELINA healthcare system will transition to Roche instrumentation. This is a huge project for the laboratory. For us, it may be just Troponin and NT-proBNP. For the laboratory, we're talking about they're changing 190 assays. So this is a big change for them. They're consolidating platforms. They're reducing sendouts. So again, right now, the lab is working very hard on a lot of things that they're doing pretty much as we speak. This goes live at Abbott Northwestern, January 3rd, 2023, and it will gradually expand to the other hospitals, United, Mercy, and so on within ELINA. But it's expected that within early 2023, pretty much all of ELINA will transition to Roche instrumentation. How does this impact us in cardiology? It will impact regards to what we're speaking today, which is that we will transition from the conventional Abbott cardiac troponin I assay to Roche high sensitivity T. And it will also mean that we're changing from the brain natriuretic peptide to Roche NT-proBNP. So these are important changes, of course, for us. I do want to recognize that, that this is something that we've been actually working together now for about 3 months, a number of us. So once we learned that we were going to implement high sensitivity cardiac troponin T, we pretty much put together an implementation team that was largely led by our colleagues from the laboratory. As I said, this is a huge project at the enterprise level. So Dr. Lawrence Anthony and Dr. Brenda Katz from laboratory medicine have really pioneered and led efforts of this huge project from the lab perspective. And on the right side, from the clinical perspective, we have really partnered on developing the protocols and the educational material and how we're going to roll this out clinically, and it's been truly a wonderful multidisciplinary effort with Dr. Laughlin from emergency medicine, Dr. Lefebvre from internal medicine, and several of us from cardiology that have partnered in this, as well as several key members listed on the right. We've been pretty much meeting every hour, Thursday, 7 a.m. for like about almost 3 months to try to put this together. So what is a high sensitivity assay? I think there's often a lot of misconceptions and confusion about what is a high sensitivity assay. And you hear a lot of terms, ultra sensitive, super sensitive, and so on. The nomenclature, it's pretty clear that it's only 2 terms. They're either contemporary cardiac troponin assays or high sensitivity assays. Right now, the one that we use in our current present practice is a contemporary assay. And these assays are defined by only 2 metrics: analytical sensitivity and imprecision. If they measure less than 50% of a healthy cohort and they have variation up to 20%, they're contemporary. That's what we use right now. So what we're shifting to is to an assay that has a very superior analytical sensitivity in healthy individuals. If we measure right now in the room, it would provide a measurable concentration in more than 50% of us, and the results are pretty tight. You can be very confident that what you're getting, it's not because of an analytical error. It's less than 10% variation. That's what defines a high sensitivity assay. And the issue of imprecision, it's critical because as we shift to high sensitivity, as shown here in red, rather than having this wide confidence intervals and errors with regard to your results, you can pretty much can be more confident that whatever result you're getting, it's more likely to be true because of the precision of the test. And this is important clinically. I mean, this is just from one study that we actually did a few years ago, in which in green you can see results from the conventional cardiac troponin test. And if you're seeing these patients clinically, you may think, hey, this patient is having a dynamic event. There's a rising and or falling pattern, and maybe you're going to start heparin or do a bunch of evaluations. But as you see on the background, we measured a high sensitivity assay, and what we confirm is that those patients had no change. So pretty much that there was a potential for one being confused by analytical variation. And this is an important thing because, again, there's a little bit more noise with those tests. Something that's key as we do this transition is that it's important to know our assay and what we're shifting to. We don't have to go over all this table, but this is just to illustrate that there's a wide variety of manufacturers in the U.S. marketplace. There's different manufacturers, different assay types. There's a bunch of different thresholds. And this is even the fact within our region, within the state. If you think about the U.S. marketplace, these are the FDA 510K cleared high sensitivity assays. There's only one T assay from Roche, and there's several high sensitivity cardiac troponin I manufacturers, Abbott, Beckman, Siemens, Ortho. So just understand that there's some variation. And sometimes I get some questions as to, well, can I correlate the result from X hospital that was X compared to this hospital in our assay? What does that mean? The reality is that there's no easy way to compare because as shown here, these are pretty much different assays. They use different capture and detection antibodies, and therefore they have different thresholds, and one cannot compare one to the other. That's pretty much the short answer as of now. So why? I presented the pragmatic rationale of why we're transitioning to high sensitivity because that's pretty much what Align is doing by early 2023. But there's something beyond that as to what has happened in the field of cardiac biomarkers and how we evaluate patients with ACS. And the reality is that there's been a shift from CKMB and enzyme-based assays to protein assays and cardiac troponin. I'm actually trying to see whether we can change the enzymes type, EPIC, to protein, right? Troponin is not an enzyme. The reality is that if you think about it, since the early 1990s, it's been an era of troponin now for about 30 years, right? And now we are entering the era of high sensitivity assays, which for us it's going to be something new. The rest of the developed world has been using high sensitivity assays for over 10 years. And so we're pretty much catching up to what the rest of the world has been doing. You may wonder, do we really need to be more sensitive? What's the rationale for that? This is actually a landmark paper from the PACE group in Switzerland, published in the New England now several years ago, in which they looked at the conventional fourth-gen cardiac troponin T assay. And what they showed is that if you were more sensitive, you could achieve a way higher area under the curve at a much shorter time period. And this was the rationale that said, like, we can pretty much have a more robust diagnostic performance earlier. And that's pretty much the rationale of even within our healthcare system, what motivates to some degree the change besides the fact that we need to change instrumentation. If you see here at the bottom, this is actually a snapshot of one of our order sets from the ACS admission order set. And right now our admission is that you get pretty much a cardiac troponin I every 3 hours for 3 occurrences. So in ideal scenarios, for you to be ruled in or ruled out, technically we're advocating for it that it's at least 6 hours. And if you think about 6 hours in this day and age that we are short-staffed and short on beds, that we really need to move patients quickly throughout the hospitals, this contributes to delays in excluding disease, patients that stay in the ED, in ops unit, and they get evaluated, and delays in ruling, patients that sometimes have an MI, it's just taking a while to diagnose them. So this is the old dogma of how to evaluate patients with symptoms suggestive of ACS, right? You have a patient that you're concerned about ACS, you get an ECG, you get biomarkers, let's get a stress test to further restratify them, let's see what else needs to happen. The present dogma is that pretty much can we simplify and perform a rapid triage in the emergency department well within an hour or 2 hours and try to figure out, is this patient very low risk, can they go home? And this is an important asset, particularly for emergency physicians, to try to really reduce overcrowding in the emergency department. So again, just to illustrate what the shift will be, is this will be the change. So our current approach, which I recognize it's not as clear as presented here, there's some variation even within our system, but it's technically a 0, 3, and 6 protocol that takes at least 6 hours to evaluate patients. And as you may know, many of our emergency departments use point-of-care assays, so there's not a standardization as to how we evaluate patients. So there's no clear standard and no clear guidance on deltas. As we move forward to the era of high-sensitivity cardiac troponin, we will shift to a 0 and 2 hour protocol that will be standardized across the healthcare system. If we need a 4-hour sample, that will be needed on a clinical basis, and there will be established guideline and algorithm across pretty much the entire ALINA system. And this is the order set will be a 0 and 2 hour reflex that will be used. What is the evidence for this? We could talk about evidence for a long time, but I've pretty much selected just to talk about the randomized clinical trials. This, I think, has been truly I've been working on this area now for over 10 years, and it's been very impressive to see how we have shifted from single center, sometimes retrospective observational studies to now large multi-center prospective randomized trials. There's now over 30,000 patients that have been randomized in some sort of risk stratification pathway using high sensitivity assays. These are the 3 largest trials. High Stakes from Scotland was a 7-site trial of over 31,000 patients. Rapid TNT used a high sensitivity T assay, over 3,000, and Loaded was just over 600 patients. But the message is consistent. The primary benefit, the primary advantage of implementing a high sensitivity assay is that one can rapidly identify low-risk patients with 1 or 2 tests, and all these trials, as highlighted in yellow, are pretty consistent that if you meet that metric with whichever algorithm or pathway they're advocating for, is that the event rate is very, very low, and that you have an excellent negative predictive value and sensitivity. So that's pretty much the main benefit of incorporating a high sensitivity assay into the practice, that you can rule out more faster and be confident that you can send the patient home, without hopefully any major consequence. What about outcomes? The reality is that the largest data on this actually comes from a randomized trial called High Stakes, also from the same group in Scotland. They've been doing very wonderful science with a number of stepwise cluster randomized control trials. This was actually their first trial that they did in Scotland across 10 hospitals. And what they did is similar to what we're doing in our practice, going from a contemporary to high sensitivity. They took the opportunity to say, we're making the transition, but within the transition, we're going to incorporate a stepwise cluster randomized trial. And they asked them the question, did this improve clinical outcomes? And the reality is that at their 1-year publication in The Lancet, there was no difference in the primary endpoint of myocardial infarction or cardiovascular death. So thus far, the main message in this field has been that we improve emergency department patient flow and length of stay, but we're not improving hard outcomes. However, I do want to at least raise to your attention this data. This is from the same group. They just presented in Barcelona a few months ago. Now they're 5-year outcomes. And at 5-year outcomes, they say that there is a significant reduction showing an association with a lower risk of their primary outcome of myocardial infarction or death, particularly in patients with non-ischemic myocardial injury. So I haven't seen the latest publication on this, but they just presented pretty much this at Barcelona, suggesting that if you follow these patients long enough, so it seems like that transitioning to a high sensitivity assays, there might be some improvement in clinical outcomes. I think we need more data on this. This hasn't been yet published, but this is the 5-year outcomes. So what do the guidelines tell us? We've talked about why we're doing this at Alina, or what are the trials, what do the guidelines tell us? As I alluded earlier, Europe has been ahead of us in the US for at least a decade. They've recommended high sensitivity assays as class 1 recommendations since 2011 with a 0 and 3-hour protocol, and their subsequent 2 iterations in 2015 and 2020 have also recommended high sensitivity assays, with the latest iteration as shown here with a 0-1 and 0-2-hour protocol, both class 1 recommendations. 10 years afterwards, finally in the US, just a few months ago, the 2021 AHA-ACC finally made a new iteration of their chest pain guidelines, in which they do recommend as class 1 that high sensitivity assays are the preferred biomarker. And I won't be showing all of these recommendations in this talk, but if you go to the guidelines, there's a number of recommendations for different aspects of risk stratification that they do incorporate in their guidelines. So what is the US experience? So as alluded to before, the reason high sensitivity assays were used broadly outside the US and not here was largely because they were not cleared here until recently. These assays were cleared by the FDA until 2017. The first assay that received 510K FDA clearance was actually the Roche assay that we will be implementing early next year. And following their 510K clearance, several other manufacturers were cleared. And therefore, that gives you an idea that at the most centers have just a few year experience depending on when they implemented this. Just within the region, as shown there, many of the centers that refer to us or that we partner with are in some high sensitivity assay. Hennepin is in Abbott, Richview is in Siemens, and I hear some rumblings that they may be transitioning to ortho. So even within our close colleagues like Richview, I think they've had at least almost a 1 or 2 year experience with the Siemens high sensitivity assay. U of M and Mayo are in Roche high sensitivity T, and we will be transitioning to Roche C. So even within the region, this has gradually become the standard. What is the impact of implementation? Our group, our research group at Mayo actually had published a lot of the early data showing what happens when one transitions. Because as you may remember or may still feel that way, there had been a lot of concerns and reservations. Then when we transition to high sensitivity, this is going to be a total headache. We're going to use a lot more tests, and it's going to break the system. What's going to happen? Keep in mind that systems, for example, like this data that I'm showing from Mayo and many other healthcare systems did this. They were transitioning from the old T assay, which is a fairly insensitive test. And they were moving to a high sensitivity, and that can be a tremendous increase in positivity rate. So there were a lot of reservations as to what was going to happen. So this was one of the original data sets that we looked at. This was across their entire healthcare system of 18 hospitals, not including Rochester. And we looked at 12 months before, 12 months post. And as you can see here, with the transition to high sensitivity, this is looking at ICD codes because it's large big data. There was a small increase in myocardial infarction, largely because of more type 2 MIs, but there was no overall increase in hospital admissions or resource use, except at the primary referral hubs, where there was a spike in more echocardiography. So this was initial early data that was reassuring that at least we didn't see an overwhelming system breaking down by a wealth of hospital admissions, and this was pretty reassuring data. we went ahead and we actually did now a patient-level study, and we're actually the first group to publish this in the U.S. last year in JACC, and we did now a patient-level analysis that we looked at the pre and the post-implementation of high-sensitivity cardiac troponin T, and I want you to look at these numbers because this is what we will likely be observing as well in our experience. But pretty much we went from a population that largely had values that were so-called negative below the 99th percentile to a population that had now almost 50% of patients will have a value that it's above the 99th percentile. And if you adjudicate them, most of them will have myocardial injury. So myocardial injury, I mean an isolated cardiac troponin increase from heart failure, sepsis, critical illness, PE, so on, but also an increase in myocardial infarction. And this is a very important observation that we're seeing more and more. We observed it here. We're not the only ones that have made this observation, but there's a shift in myocardial infarction that from being a similar frequency type 1 and type 2 MI, as one becomes more sensitive, type 2 myocardial infarction becomes the predominant MI subtype, and other groups have made this observation. So this is pretty much what we saw. And similarly, a lot of questions about resource utilization. What we found here is that similarly to our initial data looking at codes, there was no significant increase in resource utilization, which was very, very reassuring. And particularly for the emergency department colleagues and healthcare systems, which really like this message, is that if you have troponins that are negative, there's a significant increase in patients being discharged directly from the emergency department. This is pretty much the primary advantage of this, as I keep repeating. And we proved that this was of benefit because there were more ED discharges and also fewer cardiac stress tests. So essentially, emergency physicians are more confident in the ER that if they fit the low-risk protocol, they can send these folks home without additional testing. Other institutions have replicated the same message. This is an experience from UT Southwestern. They use a 0-1-hour protocol. They showed that their emergency department dwell time reduced significantly without any change in 30-day MACE. So that was pretty reassuring data, also huge data from UT Southwestern. UC Davis did a similar tabulation. This is their 0-1 high-sensitivity T implementation. And also reassuringly, they showed that if this is incorporated with protocols and education, there was no significant increase in admissions or cardiology consultations or admissions, nor procedures such as cardiac catheterizations. So I think the message has been consistent that if this is implemented carefully and thoughtfully, and there's a lot of education, it doesn't really create a lot of the concerns that existed before implementation. And one of the latest publications also in JACC was from the Mass Brigham experience. And what they showed is that these protocols, inevitably because they're mandating a more structured approach, there was an increase in ECGs. But besides that, there was actually no significant increase in things like echo. There was actually a reduction in stress tests and cardiac CT, and actually reductions in hospital admissions and cardiology services being involved. So the consistent message across the published peer-reviewed literature, and this is of course selective to that has been published, but has been pretty consistent that there has been not an increase in resource utilization. What is going to be our approach and rationale? And these slides are going to be available online. We're going to have a website in which we're going to put a lot of educational material. Feel free to spread the message because we're a month away from this, and I think everybody needs to be familiar with this. It's going to be a big deal. So these are the big changes. So what's happening? We're going from the Abbott cardiac troponin I to Roche high sensitivity T. What does this practically mean? First is that there's a change in reporting. So with a conventional test, the approach is decimals, as you can see here. You're all familiar to these results, like 0.032 nanograms per milliliter. With high sensitivity tests, the consensus from a laboratory guideline perspective is that one uses whole rounded numbers. So the numbers will look like this, like 7 nanograms per liter. So as you can see, the units change to nanograms per liter. The rationale for this is because from laboratory experience, and we see this sometimes in notes and everything, is that by adding that decimal, sometimes there is potential for error. and what it's at 32, it's at 3.2, or what was 320 was 32. So the idea is to move away from decimals and commas, all rounded numbers. Second, rather than having a uniform threshold of 0.034, which is the one that we currently use, there's a wealth of data that goes beyond the scope of this talk. I have, I think, one slide about it, is that it's clear that men have higher thresholds than women. And because of that, we will have sex-specific thresholds. For men, less than 16. For females, less than 11 nanograms per liter. So change the sex-specific thresholds. And the protocol, we will go for a 0, 3, and 6. And as I said before, I recognize that we actually have sort of like some variation within our system, that sometimes we use point of care, and I'm not sure that everybody adheres to a 0, 3, and 6 consistently, but now the laboratory, and again, as I said, this goes above us because the laboratory is a standard across the entire Alina system. The laboratory will mandate a 0 and 2 hour protocol with a 4 as an optional. I've talked about the 99th percentiles. The HACC CHESPIN guidelines actually want you, as a class 1 recommendation, to be familiar with the 99th percentile. And the reason is because all guidelines, ESC, ACC, AHA, the Universal Definition of MI, pretty much every major cardiology document that exists will recommend this threshold to define myocardial injury and support the diagnosis of myocardial infarction. The sex-specific thresholds that we will use are the ones that I've alluded to, and it's largely because there's significant sex-specific differences in those concentrations. Some people would advocate because men have larger left ventricular myocardial mass, so it's larger hearts. Why is that relevant? I do want to show 2 slides about the importance of sex-specific thresholds. This was actually one of the first and most important provocative studies that came now 2015. It's been a few years ago. And some people, this group from Edinburgh, were the first to suggest that have advocated that maybe the reason there's been an underdiagnosis of myocardial infarction in women. You've seen this message again and again, that we are underdiagnosing women with MI. They're undertreated, underdiagnosed. They've said, like, maybe they are underdiagnosed because we've been using the same thresholds for both of them. And this is from their data. They used a contemporary assay, same as us now, and they showed that as men had a higher proportion of type 1 MI as compared to women. And now, as shown over there on the right, when they transitioned and compared this to sex-specific thresholds, they showed that those differences were no longer observed. So they suggested that maybe the reason there's been underdiagnosis is because we were using overall thresholds rather than sex-specific thresholds. Interestingly enough, this is the same thing that we showed at our experience upon high sensitivity T implementation at Mayo. So as I said, just focus on the box on the left, same message. Systems like Mayo were using the 4th Gen T, and with the 4th Gen T with an overall threshold had the same message: more myocardial infarction in men than women in red. When we transitioned to the high sensitivity assay, there were no statistical differences across the board. So it appears to be that the use of sex-specific thresholds improves diagnosis in both, in women and equates diagnosis. So this will be a summary of how the results will look to us starting 2023. As I have already mentioned at length, sex-specific thresholds, men less than 16, female less than 11. An important message, this actually applies to all laboratories, so I think it's a good educational opportunity, is that laboratories don't usually measure to 0. They measure to whichever is the lowest concentration that they can report reliable. So for high sensitivity T, the lowest that they can report, which is per the insert package of the manufacturer, per what the FDA allows them to, is less than 6. So less than 6 will be the lowest number that we will be able to see with a T assay, and it will go up to over 10,000. That will be the largest number that can be reported, 10,000, and anything above 10,000 will be over 10,000. So that's how the results are going to look to us. Some of you may ask me, well, why are we not doing the 0 and 1 hour pathway? You might have heard about the 0 and 1 hour pathway. There are several institutions that have adopted that in the US, and several institutions do that in Europe. Actually, the European guidelines recommend class 1B, both 0, 1, and 0, 2 algorithms as shown here. Keep in mind that the European algorithms cannot be adopted specifically per se in the US because these concentrations are not FDA cleared. But the rationale we're not adopting the 0, 1, it's for two reasons. One, it is very cumbersome to get, and Amy can speak to this since we were just talking about it. It is very cumbersome for a large multi-center healthcare system to do that 0 and 1 hour samples and report it in a practical time. So the 0 and 2 is way more practical for sophisticated large healthcare systems, and that's pretty much what most hospitals in the regions are doing. But two is that the 0, 1 hour protocol, and this is a snapshot from that 0, 1 hour protocol, uses very small deltas to allocate you into a box as to whether you're low or intermediate or high risk. And as you can see, those very small deltas, if you get to very small deltas, you are prone to some analytical imprecision. So there are some in the field. This is from one of my good friends, Alan Jaffe, who has this slide that he shared with me. And he's an advocate, for example, that would not push for the 0, 1 because of some of these concerns about imprecision. So we're adopting a 0 to hour protocol in part for that reason. This is some of the data on the 0 and 2 hour protocol that we will adopt. Keep in mind that ours is a little bit adapted because of some of the things that have changed in the field, but it's the same thing. If your values are below the upper reference limit and you have no significant change, your sensitivity and NPV are excellent, over 99%. If your concentration is markedly increased in presentation, or there's a significant change over time of 10 nanograms per liter, you'll have a specificity of about 96% and a positive predictive value of about 78 to 85%. So again, the primary benefit of these assays, as I've said throughout the talk thus far, is that you will have very excellent sensitivity and negative predictive value. So over the next few slides, this is actually educational material. This is a little bit longer version, but there will be like 10 slides of this in the AKN, but it's pretty much the next few slides that we're gonna go over. So it is simpler than what it appears. Pretty much this is actually from the European guidelines, which I think it's a nice approach. It's only 3 bins anytime you see a patient. If you see a patient that you're suspecting ACS, if your initial troponin is very low, or it's low with no significant change, you're low risk. I think this is pretty much what we're still doing even in our present practice without high sensitivity tests. If your initial troponin is very high or you have a change, you are at a high risk. We need to evaluate that patient further. And if you're neither here or there, you fall in an intermediate zone in which we are supposed to consider additional evaluations. How does that look with the T assay? It looks as inserted there. That means that to rule out, you need a troponin less than 6 with symptom onset more than 3, or 2 troponins that are so-called negative below the upper reference limit with no change less than 3. That puts you in the rule out bin. If you have a concentration more than 100 or a change more than 10, that's a higher risk patient that it will rule in. I want to clarify that the rule-in language does not mean rule in everybody has an MI. That just means that you're rule-in for a higher risk patient for acute injury, higher risk for type 2 MI. It's higher risk for something acute is happening, not necessarily an acute myocardial infarction because that needs a clinical correlate. And others, you will get a 4-hour sample and you will use the HERE score. And I will elaborate on this a little bit further. Let's start with the first group. So this will be particularly important for emergency physicians, and I'm actually meeting with them later this week. But if you rule out a patient, this is how you will do it. You, of course, we cannot forget about the ECG. These patients must have a non-ischemic 12-lead echocardiogram. There will be 2 options in how they can rule out a patient. This is a big deal as we transition to high sensitivity tests, is that now the guidelines endorse using a single sample in selected patients to rule out a patient appropriately. So if your concentration is below 6, which as I said before is the lowest concentration that you can report with this test, you have symptoms more than 3 hours without recurrence. So you're not an early presenter. You were not just having this pain over there in the corner in the street 20 minutes ago. You have a non-ischemic ECG, you're eligible to be ruled out with a single sample. This is a big deal. We did some data analysis that showed that about 30% of patients are eligible for this approach. So imagine many patients coming to the ED. If they meet this metric with a single sample, they should be able to go home. That will save a lot of beds in OPS or additional testing. Serial testing. Serial testing is the 0 and 2 hour protocol. As I said, below sex-specific thresholds with no change. What is no change? No change is less than 3 nanograms per liter. This is just to emphasize that the guidelines do provide a class 2A recommendation, then a single sample approach. It's reasonable. Interestingly enough, they gave a B non-randomized level of evidence, even though there are 3 randomized trials evaluating single samples. So rule out, just be aware that there's a lot of data for this. What about the ruling group? The ruling group, as I've mentioned, and I want to emphasize here, being high risk does not equal to acute myocardial infarction. Acute myocardial infarction is a clinical syndrome. It's a clinical diagnosis. It's not a biomarker diagnosis. So having a metric with a biomarker perspective that their concentration is high above 100 or a change of 10 helps you identify those high-risk patients. For you to say that they have myocardial infarction or suspected MI, they need something else, right? They need ischemic symptoms, they need wall motion abnormalities, they need an abnormal angio. And this is going to be, as we implement this, there's going to be a key thing of what we do if we're getting called consults or triage or curbside. It's just not about the biomarker, right? It's always about what is this clinical correlate and the clinical context. But keep in mind that if the test is used appropriately in patients with chest pain, a concentration above 100 or a change over 10 is associated with a high positive predictive value. All these concentrations that I'm talking about right now are a guide. They're not perfect. And the reason I say this is because for both ends, to identify low-risk patients or high-risk patients, this is illustration from another assay, but it makes the point, is that there's a continuum in risk. So if you choose a higher threshold, you get a higher PPV. If you choose a lower threshold, you get a higher MPV. So there are thresholds that are selected. None of them are perfect. You may be asking me, why 100? Why not 50? Why not 70? Why 100? And partly it's because of data from the APACE group that it shows that, again, in the right patients, if you have a patient with a good ACS story, chest pain or chest pain equivalent, with no other alternative explanation, at presentation of a concentration above 100 is a positive predictive value of almost 90%. So in the right setting, a concentration in this range should raise some concern. However, it's not perfect, and it's not perfect particularly in the United States, particularly in the populations that we see in the emergency departments, right? We see a lot of folks that have end-stage renal disease, CKD, cardiomyopathy, transplant patients, and so on. Many of these patients will chronically have troponin concentrations in those ranges. So that's the reason I say clinical context is key. Just to emphasize on language, we need to shift away from terms that do not exist in the medical language, such as troponinitis, troponinemia, troponin leak. Many of these things, such things are not in any medical textbook. Somehow they've been incorporated to notes, and they just made it somehow into the medical nomenclature. The nomenclature that's advocated is you either do not have injury or you have myocardial injury. That's pretty much it. So if you do not have myocardial injury if your values are below the 99th percentile, and if your values are above the 99th percentile, you have myocardial injury. And it's our job to figure out whether this myocardial injury, it's acute, chronic, or MI. So it's very similar to CKD. If you have an increased creatinine, you're thinking, is this acute CKD, or acute kidney disease or chronic kidney disease? Sort of think of that as an analogous approach. Last, the intermediate group. This is the group where the patients are neither clear here or there, and you're like, what should I do? In these patients, we're allowing for a 4-hour sample to be measured and for emergency physicians to use the HERE score. What is the HERE score? Some of you may be familiar with this. The HERE score is essentially a specific score that has been validated in the emergency department physicians to evaluate patients with suspected ACS. It is history, ECG, age, and risk factors. So if you're for our colleagues in the emergency department, if they're faced with one of these patients, they're on the fence about what to do, they can calculate the score, And if the score is less than 3 and the troponins, as I said, are on the negative side of things, they're not suggesting anything high risk, they can consider outpatient follow-up. On the other hand, if this score is increased and some of the initial information in ECG or troponin is equivocal, additional testing would be recommended, and the guidelines do suggest that. At AVID, and we have Dr. Cavalcante here with us who participated with us at the meetings. At AVID, we would advocate for coronary CT as the preferred approach in select patients if they meet those metrics. Important things, caveats to mention is that I've talked a lot about absolute changes, right? Just to emphasize what those concentrations are. No change less or equal than 3, change more than 10. Those are the concentrations that help identify low-risk patients or high-risk patients. However, if you have marked troponin concentrations at presentation, absolute changes are not recommended. What's changed is relative or percent changes, and those are percent changes of 20%, as mentioned here. This is, of course, a lot of information that I've just delivered. All of this will be available in complete algorithms in the AKN. This is a busy algorithm, but the purpose of this algorithm is that if you're in an emergency department anywhere within our large healthcare network, let's say it's 2 a.m., that you can pull this and essentially go through a path and use this as a resource as to how to evaluate these patients. But in brief, this is what you're supposed to do. If you're ruled out and meet all those low-risk features, you can just follow up with your primary care. And again, this is a guideline, this is a suggestion. If you have, of course, an increased troponin with a significant delta and you have ischemic features, symptoms or ECG, those are the patients that we should hear about, right? We need to be involved with those patients. They should call us to consult on these patients. We should evaluate them as needed. If they're intermediate high risk, there are some patients here that can have that may need a stable angina, but some of them may require additional tests. And it is those patients, these 3 bins, chronic injury, and acute myocardial infarction, that we'll be hearing about quite a bit. What are the challenges? We need to prepare, partner, and educate. And it's largely because we already know this. We already know this even with the present troponin test, is that we already know that troponin has an excellent tissue specificity. It is rare that troponin is increased in settings that is not because of MI, but it's not disease specific. And I want to highlight you again the data from our recent publication with the T-assay. Most troponin increases will be from myocardial injury and type 2 myocardial infarction, not type 1. So therefore, we need to educate our colleagues and ourselves about how to best interpret this test. This is preliminary data that actually I was shared. It's yet unpublished, but I think it's important for our group, by my friend, colleague, Fred Appel. We have a study called Contrast that has different assays. It involves the assay that we're using right now and the assay that we will be shifting to. So we will likely see, we have to do further analysis, and we will hopefully publish this soon, but there's limited data going from the I to the T. Most systems transition within their own manufacturer. Most systems go from, let's say, Abbott TNI to Abbott high sensitivity I, or from Roche TNT to Roche high sensitivity T. We're changing manufacturers, so there's less data on that. So this is one of a few pieces of data that I know about this, and that means that there will be an increase, as shown here, of about 20 to 30%. So I think we need to prepare accordingly for that. And the reason there will be some growing pains is because of the many things that we all know when we're in the hospital doing consults and so on. It's because in the US, this is not reflective of our institution. Everywhere in the US, the data is pretty consistent that troponin is used unselectively, right? It's used in patients that have fatigue, shortness of breath, syncope, it's used broadly. And this is one piece of data that if you use the test broadly, there you have more myocardial injury and more type 2 myocardial infarction. Irrespective of the latter, I think it's important to go back to the high-stakes randomized controlled trial and just emphasize that the implementation of high-sensitivity cardiac troponin has not been shown to have any safety signals of anything adverse. I want to highlight again, clinical context remains absolutely key and essential. I really like this slide from the Assay group that was published in Clinical Chemistry. And here, this is actually the assay that we will be using. They tabulate the high sensitivity T assay above the 99th percentile or more higher increases. And they illustrate nicely how pretest probability remains crucial to evaluate results. If you have a troponin that, let's say, it's modestly increased above 52, but the clinical presentation doesn't sound like ACS, only a quarter of them actually meet the end-STEMI diagnosis. On the other hand, if you have even a mild troponin increase, but you have a high pretest probability, 73% are likely to meet the end-STEMI criteria. So again, just to emphasize, this is not rocket science. All of us know this. Clinical context is key. What are those symptoms? What are the ECG? Is there anything else happening? These are the things that I think are going to be key that we educate our colleagues from everywhere, right? Hospital medicine, internists, residents, our colleagues, our fellows, is for us to use this efficiently, we need to understand what we're dealing with. What is acute injury? Acute injury, it's just an isolated cardiac troponin rising on or falling pattern without ischemia. These are all the patients that we see all the time. Heart failure, cardiomyopathy, myocarditis, PE, sepsis, critical illness. They have troponin changes. They may have even some ECG changes, but they have no overt ischemia. They are myocardial injury. There will be many patients that will have long-standing chronic troponin increases. The changes technically should be less than 20% over time. These are patients with chronic heart failure, cardiomyopathy, ESRD. We should educate that these are chronic changes without ischemia. And this is probably, I would argue, one of the most important slides because sometimes even us in cardiologists, there's some confusion about what is an MI, and sometimes, and this is not actually surprising. Studies have shown this. Sometimes we use the term MI, but when we adjudicate for it, they don't meet MI criteria. So I think it's worth emphasizing what is an MI. It's a rising and falling cardiac troponin concentrations. At least one value should be above the 99th percentile, and there must be clinical evidence of ischemia. That means at least one of the following criteria: symptoms, ECG changes, Q waves. Is there imaging abnormalities, new regional wall motion abnormalities, or is there some feature and angiography that supports the diagnosis? If none of these features are present, then these patients do not have an MI. And I think this is part of what we need to educate our colleagues as we transition to a more sensitive test. I won't go over these slides, but I do want to highlight this was just published like a month or two ago, the 2022 ACC Expert Consensus document. It's actually a nice resource because it provides tools about how to clinically evaluate patients with injury and type 2 myocardial infarction. The reason I bring this up is for the following. As one transitions to high sensitivity, but even with the present test, it is rare to have false positives. One can have them, and I'm not talking about them here because there's a whole analytical talk about that, but most increases are reflective of true myocardial injury. And the general message that we need to have is that if there is some myocardial injury, we need to ask ourselves, why is that? Is that because of some underlying structural heart disease? Is it because of underlying ischemic heart disease? So that's what the guidelines with this expert consensus is pushing to, is that rather than saying, oh, this is a non-MI false positive, is that this patient had some injury. Is it because the patient has, let's say, LBH and some horrible valve disease? So the recommendation is that these patients need to be evaluated further. Same for type 2 myocardial infarction, with a suggestion to look more for CAD in those patients. As we wrap up, I want to talk about areas of caution. There are some important areas of caution. I talked about the single sample test. The single sample approach will be recommended, is recommended in the guidelines. We are adopting it. Less than 6, more than 3 hours will apply. But that's the key issue. Patients need to have symptoms without recurrence for more than 3 hours. This is from the high-stakes groups. If you use a single sample approach in early presenters, patients that had symptoms, let's say in this particular case within 2 hours, the negative predictive value totally drops. So one should not use a single sample approach in patients that are early presenters. Another important caveat, and we actually So a number of these cases that we actually tabulated ourselves during our implementation at Mayo was the late presenters. We talk about all these issues of dynamic rising or falling patterns, and a change of 10 is significant, and a change of no than 3 is not significant, and all these algorithms are published in all these publications. But all of this assumes that patients present perfectly every time after their symptom onset, and that we're going to catch this rising curve. And as we know, that is not true. Many patients will present to the emergency department after being at home with symptoms for 10 hours, and they finally decided to come in. So they may not present when the values are rising. They may present here. And if you get a sample at 0 hours and 2 hours, you may say, your troponin is not changing. This may be chronic injury. Go home. Clinical pretest probability is key. So there will be patients. There was one study that suggested it could be up to 26%, but there will be some patients that will have an MI diagnosis. The reason they have no change is pretty much because we're sampling at this plateau phase. If you really, really want to say, oh, they have something acute, you just get a third sample, and the third sample will show that there's a fall. But this is an important caveat, and it's not infrequent. Unstable angina still exists. Eugene Brownwald and Dave Morrow published in Circulation a few years ago a piece called Requiem for Unstable Angina. And they suggested that when one transitions to high sensitivity, unstable angina will disappear. In our practices, we adopted high sensitivity, and many others have shown this, is that it is infrequent, but it still occurs. And this is like a case example of somebody that had troponin actually less than 6. So just keep in mind that even in patients that so-called meet that very low risk group, there will be selected cases that will have high risk, that will have the real deal. So again, clinical context, it's fundamental. I will wrap up with the last point of outpatient applications. And again, this is a theme that could be a total separate grand rounds and sessions at meetings, is that we're catching up on this task 10 years later, and we're incorporating it in our practice to evaluate patients with suspected ACS. Where the field is going, and in some places it's already incorporated, is to outpatient testing, because this test is now so sensitive that it has shifted to risk stratify patients in the office setting. There's actually one analysis that we did from MESA that we published in JACC a couple of years ago, just to make the point. This is coronary artery calcium score, a well-established and validated marker of risk. This is high sensitivity cardiac troponin T. They have a pre-analogous risk stratification, and in this particular data, the message was that if they're used conjointly, they enhance risk stratification. I'm not telling you that you must do this. I'm just raising the point that this and the applications continue to emerge again and again. The applications which go beyond the scope of this talk go from cardio-oncology, primary prevention, secondary prevention, atrial fibrillation, cardiac amyloidosis, hypertrophic cardiomyopathy. The list goes on and on and on. This is just one other study for atrial fibrillation in which they say how the CHADFA score has a pretty poor C-statistic of just 0.59. And if you use some of the more novel scores, such as the ABC stroke score that was published in Circulation by David Morrow, that incorporates biomarkers such as T and NT-proBNP, you get a better, albeit still modest, but a better C-statistic of 0.67. So there are many that are using now biomarkers in the outpatient setting for this reason, and it will be an important change in our practice. And because of that reason, there will be a specific EPIC order that if you desire to use troponin for an ambulatory indication, where the attestation that the patient is not having chest pain in front of you, that you can use this in the outpatient setting. And I think that actually will be a reasonable thing. So as we finish, this is one of my last slides. I want to add with a quote from Robert Jesse. When troponin was a lousy assay, it was a great test. But now that it's becoming a great assay, it's getting to be a lousy test. I realize this can be painful, and we will all be reminded of this when we're on consults during the implementation phase, but most systems have been able to get over the hump without any issues, and this has been able to succeed and work at most places. Think about what the past is. The past is Troponin, a binary test in which it was used sort of as a pregnancy test, negative versus positive. Delays in diagnosis due to prolonged sampling. More samples are needed, more analytical noise, more uncertainty. Are you really low risk? Leads to a stress. This leads to a coronary CT. No randomized trials, only used for MI, and we're underdiagnosing potentially women. This is the present with high sensitivity. We realize that this is a continuous biomarker that is a very robust barometer of cardiovascular health. It allows more rapid diagnosis, less samples, less analytical noise. There's less uncertainty about who is truly low risk, and therefore our emergency physicians can send more patients home with confidence. Now we actually have several randomized trials rather than observational studies to support this. The applications continue to emerge about outpatient applications, which is where the present and future is going to, and there's a push, and we're moving towards sex-specific thresholds to improve diagnosis in women. So my take-home point is that pretty much clinical trials and practice guidelines recommend high sensitivity as the preferred test. So we're moving to that practice, and we should be excited about that change that we're incorporating. The main advantage will be for rapid triage and disposition in the emergency department. The main challenge, I've alluded to that, is that there appears to be some data that there will be an increased positivity rate. And therefore, we need to ourselves learn and embrace and educate others anytime we have the opportunity, particularly during the first few months, is what is acute injury, what is chronic myocardial injury, what is type 2 myocardial infarction, because otherwise there's, of course, the concern that we can overtest or even potentially put at risk some patients if we don't understand what their actual diagnosis is. The key to interventions, therefore, is education, education, education. Clinical context and pretest probability remain essential. I've mentioned that. And there's an increasing number of applications in the outpatient testing. Something that we did not discuss today, but we've been able to secure, and I'm actually pretty excited about this, is that, as I said, an important change as we move to Roche instrumentation is that our natriuretic peptide testing will change. So we're changing from BNP to NT-proBNP. So Professor Dr. James Janussi from Mass General will be here in February 13th, and he is the expert on natriuretic peptides. So I'm pretty much looking forward to this talk. So mark your calendars on that. And with that, I'll wrap up. Thank you very much.
Share the microphone. Can you hear me? Yeah.
Yes.
Yader, that's great. Thank you so much. Two quick things. One is a comment, one's a quick question. I work a lot at Ridgeview. I'm there probably about a third and half the time. We had the exact same concerns that everybody else does. We're going to get called nonstop. What's really interesting, what actually occurred was that the ER became much more thoughtful about this. It was no longer this, oh my gosh, there's a slight elevation troponin, call cardiology stat, they got to get down here right away. Now it's this, they expect everybody's going to be positive on some level, and they will really think through kind of what that delta looks like. They did call us early on, a lot of questions trying to understand the assay. They expected that we knew more than they did, which wasn't always true. So I encourage everybody to make sure you really understand what the different sort of deltas look like and whatnot. But it actually has turned out to be a very positive experience for us over there. Second question is, how did we decide on that assay, on the Roche assay? I mean, because obviously they use something different at Ridgeview. That's going to be probably a little bit of confusion.
It was pretty much at the Allina level. With the folks looking at the numbers and the different offers that they had, it was pretty much a financial decision. That neither cardiology or not anybody had any. It was pretty much the best contract for a large healthcare system. Which to your point, which I do want to, which to your point, there is not one robust piece of evidence that I'm aware of transitioning from the contemporary, from Abbott to the Roche high sensitivity. So with Dr. Sharkey and Bradley and others, we've been actually thinking about, as we transition, this will open a lot of opportunities to look at the impact of implementation of this test.
That was fantastic. I'm convinced. If you have someone have an episode of chest pain and it's a certain amount of time, say 10 hours or 12 hours, what is the point where you would just go clinically and not feel, even with a negative, Because I think this is gonna happen in the ER, that the last episodes will be more remote, and they'll still be very concerned and want testing.
It's a great question. Let me just see if I can pull up our algorithm here just to have it. This is the basic algorithm, but again, it's the research. But you're supposed to get an ECG, you get your initial troponin, and right now, the algorithm that we agreed upon is that you need more than 3 hours without recurrence to say that somebody ruled out, only if their troponin is less than 6. There are some institutions, and we actually did something like this at Mayo, is that if you had symptoms for more than 6 hours, a single sample below the 99th percentile, you could say, oh, your symptoms were a while ago, and we're done. The reason we did not incorporate into the algorithm is that there is some data, actually from our colleagues in Edinburgh, that shows that if you use the 99th percentile, a single sample, even if you push it to 8, 10 hours or so, it may not be as safe enough. So rather than using the 99th percentile, we would advocate for using this concentration of less than 6. If you're not less than 6, then you're inevitably are going to have to use a 0 and 2 hour protocol. So that doesn't mean, to your point, that some emergency physician may say, hey, this patient had symptoms 12 hours ago and their troponin is negative. Can I use that single sample? I guess people can do that at their own clinical judgment, but there's no robust data to support that. And some of the data that I'm aware of actually supports against it, for which is the reason we did not include it.
Yader, congratulations on the body of work, and we are so lucky to have you here to guide us through this transition process. And I can only think of many opportunities that we have, as you alluded, changing vendors and changing assays and the learning process of that. Would like if you could just please expand a little bit more on the type 2 MI evaluation, as this is something that we'll probably would like to see a little bit more, and what expert consensus and other centers have been doing in terms of dealing with these patients.
Yes, well, as you know, that's one of my main areas of interest and passions, researching clinically. The short answer is that, as all of you know, there is no really piece of any perspective or randomized trial in this field. So any recommendation is more like an expert-based recommendation on what to do. But where the field is heading to, and this is from the ACC expert consensus, that's the reason I just pulled it up there, is that there appears to be an emerging common signal, and you're familiar with, actually both of you will be very interested, that paper in Circulation that they did a prospective, the demand MI cohort, that they took 100 patients with type 2 MI and they comprehensively evaluated them with MRI and coronary CT. And beyond that data, there's others that appear to show the common signal that these patients have are burdened, and frequently are burdened with left ventricular dysfunction and ischemic heart disease. So rather than what used to be the norm, like, oh, you just have some demand MI, let's keep walking, or some demand troponin leak, and let's keep walking, nothing to do. The recommendation is to say, alrighty, maybe you don't need to go to the cath lab, maybe you don't need stents and 2B3As, but maybe when you recover from your acute illness that we're going to support you through, we're going to think, why did you have that type 2 myocardial infarction that met the clinical criteria? And we are at least going to do some sort of evaluation, as included here. Transthoracic echocardiogram, do you have LV dysfunction? Is there underlying structural heart disease? And the other one that is suggested here in this expert consensus is, if you do not have CAD, should we evaluate you whether you have underlying coronary artery disease? There's, of course, no robust guideline that I can tell you that this must be done all the time. But many of us, including myself, if there's somebody that has, let's say, AFib with RVR, they had horrible acid depressions, and I know maybe it's demand, but they had, oh my God, horrible depression, significant rise in troponins, the suggestion would be consider evaluating them for coronary artery disease. Not because you're going to do multivessel PCI, but because you're going to say, hey, maybe you have CAD. We're going to put you in aspirin and high-intensity statin and improve their risk profile.
Dr. Sandoval, thank you so much for that excellent presentation. We do have one online question. Thank you for being generous with your time. That question comes from Dr. Timothy Dirks, who asks, is there any value in getting a baseline in certain subsets of patients?
Yeah, it's an excellent question. It's not recommended right now in any guideline. However, as I alluded to, there is an increasing opportunity to measure cardiac troponin in the outpatient setting for other indications, whether, as I said, was for atrial fibrillation or for primary prevention and so on. So the short answer is no. However, I think I anticipate that as we use this test more in the outpatient setting for other indications, and that's the nice thing that we're going to have this particular tab, is that there will be a stable ambulatory troponin in another row that will allow us to look at that and say, all right, this patient is now in the AED, but look at this. They had an ambulatory troponin measured here. So that may help serve as a baseline. And that will be helpful, but I cannot tell you to do it at this point with you.
Thank you.
Well, thanks so much. Good luck.